Well, good evening. Good evening. Great. Well, we're here to discuss such an important topic, and we're so pleased to be here. And my name is Clay Marsh, and I'm going to be the moderator of this panel discussion. And I'm going to introduce each one of our discussants and have them give you a quick background about what their frame is. But before we get started, I want to recognize and thank Betty Chilton, Trip Shoemate, and Susan Shoemate for their partnership and sponsorship here for this panel discussion. I would be remiss if I didn't recognize my boss and my colleague, President Gordon Gee and Provost Joyce McConnell. And there's so many people that I could recognize in the audience, and we have an incredibly capable and elite group of people. But I want to recognize Judge Patricia Keller and Fire Chief Jan Rader, who are well chronicled. In the movie Heroines, and if you haven't seen it, you should. It's really amazing, but also for their great work. And really, we're brought together by a tremendous opportunity here. And what we're going to talk about tonight is a step along the path of trying to come up with a set of solutions and approaches to help the folks who are suffering from the opioid epidemic. And I'm going to make a controversial statement. I'm going to say, in my opinion, despite this being a terrible epidemic, this may be a symptom of the real problem, not the real problem itself. And I'm going to compare the opioid problem or the problem with chronic diseases to a weed that we might experience in our yard. And we oftentimes see the weed from the part that's above the ground, and we start to focus on trying to get rid of that part of the weed. And in the opioid epidemic, it may be things like trying to reduce the prescription of opioids, maybe having more naloxone to save people's lives, rapid response teams, more opioid treatment, capacity, maybe jobs for people, et cetera. But I think that the root cause, and if you want to get rid of a weed, you have to pull it up by the roots. I think the root cause is what a Nobel laureate, Angus Deaton, and his wife Ann Case talked about when they found there's a group of 45 to 55-year-old non-Hispanic whites with a high school education or less that are dying at a rate that's not been seen since the peak of the AIDS epidemic. And they're dying of addiction-related problems. And as they dove deeper, they really found that they're dying of isolation and loss of social capital. They're dying of despair and hopelessness and dying of the feeling that maybe they're not worthy to have a better life. And our goal would be, and I think Mike Brumage and other people talk about this, our goal is to start to reconnect people back to purpose, back to connection, back to community, and change mindsets from scarcity and fear to love and abundance. I think that's the root cause. And if we do that right, we're not only going to help people with the opioid epidemic, but I believe we're going to help the chronic disease epidemic that we have in our country and have West Virginia be a model. So that's the frame that at least I'm pushing forward. I would like to introduce our very esteemed and very distributed knowledge panel. This is going to be a lot of fun. And what I'm going to do is when we finish with this first introduction, we have students from West Virginia Tech that will have microphones. Put your hands up on the sides. And if you hold your hand up, we will come to you, and they will facilitate and give you the microphone because we're recording this. So we would ask you to ask your question in the microphone. And then we will have a primary and secondary respondent. And we want to get through as many questions as we can. The goal here is not to have a didactic session where you appreciate the excellence of all of our speakers. The goal here is to have a conversation and to have a series of questions so that we deal with the issues that you believe are the most important. So I'm going to introduce our panel from my left to my right. First of all is Dr. Ali Rezai. Ali is the director of the Rockefeller Neuroscience Institute at WVU. He's a very recent recruit from The Ohio State University, where we had a presence, both the president and I did. And Allie is one of the most amazing innovators and creative physician creators that I've ever worked around. So we're really so lucky to have Allie here to help us in the state. So Allie, why don't you make a few comments and tell folks what your frame of this epidemic is.
Thank you, Clay, and it's been a pleasure. 3 months in West Virginia, so it's been fantastic working with all the experts at the West Virginia University and across the state. Our goal is to develop, bring forth new innovative technologies that are dealing with the opioid crisis in 3 ways. One is development of microimplants, like this little pellets that I brought with me here. I don't know if you can see it up here, probably not, but small pellets that basically block pain signals for 1 year, so you don't need to take opioids. Or this other device here that goes in your cheek that treats cluster and migraine headaches with a dramatic reduction in the need to take medications. So opioid-sparing treatments for chronic pain, so you don't start taking opioids. Second, we're bringing technology here that looks at monitoring those who are opioid addicts or any other addiction for that matter. And that involves wearable sensors that you wear, the watches, the Fitbits, and others, or other technology that our colleagues from the military research laboratories are here with us that allow us to predict the brain signals and the physiological signals before somebody is actually taking the steps to take drugs. So predictive signals linked to machine learning that is able to provide feedback to everybody about this person being more prone to addictive behavior. Third approach is using technologies such as an ultrasound technology, magnetic technology, electrical technology to reduce the addictive signals in the brain as treatment approaches. So that's the spectrum of the approaches we're looking at, from prevention to monitoring and feedback to treatments of opioid addictions and broadly beyond opioid other addictions.
Thank you, Allie. So our next panelist to Allie's right is John Deskins, who is the director of the WVU Bureau of Business and Economic Research and is our economic guru for the state. So John.
Clay, thank you. Very happy to be here to discuss this issue. I'm coming to this, of course, from the economic angle. Even though our state's economy has hit bottom and even though we've been growing again, we still have some major challenges before us in terms of economic development. And one of the biggest challenges that we face is labor force participation. Nationally, 63% of the adults want to work. Whether they are working or whether they are just looking for work, 63% of the adults want to work nationally. Those who aren't in the labor force are retired, in school, stay-at-home parent, whatever. In West Virginia, though, we're dead last among the 50 states in terms of labor force participation. Our labor force participation rate is 53%. And there's no way we could ever achieve the kind of economic outcomes that we would hope for if we have a full 10% of our adult population on the sidelines, just compared to the national average. So we have to get that labor force participation rate up to make our state more prosperous. And the point here is poor education outcomes, poor health outcomes, and this drug abuse crisis that has erupted in West Virginia, those are the 3 drivers behind the poor rate of labor force participation. So to think about it from another angle, we have to attract businesses to West Virginia, right? We're never going to get jobs, we're never going to grow unless we can make our state attractive to potential businesses. Businesses want a lot. They want a good regulatory climate. They want good infrastructure. They want good all these things. But one thing is for sure, a business is not going to locate in West Virginia unless it's confident that it can find the workers that it needs. And by that, I mean it has to be confident that it can find the workers who are educated, who are healthy, who are drug-free. So in my mind, tackling this opioid crisis, this opioid abuse crisis, is a key element of developing our economy and really achieving the prosperity that we hope for in the long run. Just aside from that, I don't want to ramble on here forever, but just aside from that, I've done some basic calculations to just get a sense of how big of an impact the opioid crisis has had in West Virginia. And I'm not even talking about it from a pain and suffering perspective or from a human perspective. I'm just talking about it in terms of dollars and cents, just very plain vanilla dollars foregone in the West Virginia economy because of the opioid crisis. I'm estimating that the opioid crisis has cost our state something around $1 billion in a state where total GDP, where total economic output is about $75 billion. That's a big impact. That's a really big impact. And we're also talking about maybe around 10,000 jobs that are foregone as a result of this crisis. So it's really top priority in terms of economic development.
Great. Thank you, John. So next we have Frankie Tack. And Frankie is leading a really exciting new program to increase our capacity to help people who have addiction. This is our Addiction Counselors Program. And Frankie, why don't you tell us about the program and tell us how that you envision this to really help change the approach that we have in the state.
Great. Thanks, Clay. And thanks to all of you for coming out tonight. It's so heartening to see so many people interested and involved, because it's, you know, one of the drums I've been beating is that it's going to take every one of us, no matter how small an impact we may be able to make. We all are going to have to be part of the solution. So, yes, my focus currently is on workforce development relative to addiction professionals. We don't have the infrastructure we currently need to treat the addicted population in this state. And as we're passing laws and we're drawing down funds and we're lowering stigma, raising awareness, wanting to get people into treatment and people's motivation raising for treatment, we don't have the professionals equipped in the state to handle that volume. So our focus right now at WVU is building programs to help train addiction professionals. Those programs haven't existed until now, and we've got a brand new addiction studies minor for undergraduate students, and we're beginning to talk about planning a graduate certificate that will be completely online for those with bachelor's and master's degrees already across the state, maybe already practicing addiction professionals who haven't gotten formal training and or would like to pursue state certification, which is kind of gets into my other concern, or I guess advocacy that I'm into right now, which is quality of care and quality of trained professionals. So we need professionals in the field. We need addictions professionals. We need them to have appropriate training. This is a specialty field in counseling. And I'm a real proponent of state certification. We have a strong state addictions board, and the new state Senate Bill 273 is building in addiction credentialing requirements. I'm so glad to see that, and I'm hoping that's going to make its way all the way through. I'm also a big proponent when it comes to quality on making sure we have the counseling and therapeutic components that go along with medication-assisted treatment. I'm real concerned that we're going to end up with Suboxone providers that aren't providing what's recommended by SAMHSA, NIDA, and Addiction American Society of Addiction Medicine, that the psychosocial elements have to be addressed with people with addiction. We just can't give them a drug to deal with the craving, which is very helpful, but we have to provide therapy to address the underlying trauma, the co-occurring mental health issues, relapse prevention, coping skills, et cetera. And when Clay talks about wanting to build towards, dealing with these issues of hopelessness, connection, community. This is what counselors do. So, and lastly, I would say another one of my passions right now is the families of those in active addiction. I think we're focused a lot on the people in active addiction, as we should be, but I'm also very concerned about the families. The families that when their family member gets into recovery, that we assume the family is just fine, and the family members who have people who die and we assume their problem is solved. Those people need care, and I think we need to be attending to them as well. Thank you.
Thank you, Frankie. Next, we have Dr. Sally Hodder. Sally is the director of the West Virginia Clinical and Translational Science Institute, which is the largest grant from the National Institutes of Health that we have gotten at WVU on the health side. Sally is also an infectious disease expert who is very engaged with looking at some of the complications of this epidemic. Sally.
Thanks very much. Good evening. I come to this epidemic actually from the frame of HIV, and I actually was an intern in San Francisco in 1980 at the dawn of HIV. And I really see many parallels between that epidemic and the current opioid epidemic. Number one, today we have more people dying in the United States from the opioid epidemic and its complications than at the height of the AIDS epidemic were dying. Number two, there was absolutely no treatment at the emergence of the AIDS epidemic, and then we started to get some drugs that had, some efficacy. And as you know, current opioid treatment, at best, maybe 50% going into remission. And I think, the AIDS epidemic was really turned around when communities came together. I would say it was really the men who have sex with men, gay community, who came together and demanded that money be put for research. And money was put for research in a very aggressive fashion, and we did find actually not a cure, but today folks who are getting infected with AIDS will live a normal lifespan. I think the second lesson is that it was really communities coming together, even after we had effective treatments, and we started to get drugs to prevent AIDS, the incidence of HIV in the United States did not decrease till very, very recently. And that was because I think there were not effective community programs that really had to be holistic. So I think that particularly West Virginia and the group brought here in this setting and others, and the great work that has been done by Chief Rader and others in West Virginia really bode well for really coming together, demanding solutions, and finding those solutions in the communities.
Thank you. Next, we have Gazette Mail writer Eric Eyre, who did an amazing job writing about the opioid epidemic here in West Virginia, and by the way, won the Pulitzer Prize in 2017 for that reporting. So, Eric.
I've been covering this issue for about going on 4 years now, and what's kind of perplexing, or the questions I have, is I'm so impressed with the talent and the energy and the everything that's going on here. I see Dr. Foster out there. It was probably Dr. Foster 3 years ago when you had the panel, and you were talking about Narcan before anybody even knew what Narcan was, and coming up with great solutions. And so I see this incredible talent, Chief Rader as well, and that's what gives me hope. That's the good news. The bad news is, with all the good things going on, and again, I think in many ways we were ahead of the curve on a number of measures that we took. But then today I had them send me the latest stats. We're already up. Drug overdose deaths are at 812, and that usually is counted through May, so we're likely going to break a record. Fentanyl was 460, fentanyl-related deaths, 466. Heroin, 216. OxyContin, 153. Hydrocodone is down. And then the two ones that we've been hearing about out of nowhere, crystal meth, 182 overdose deaths. And cocaine is making a resurgence. And amphetamines, so if you put amphetamines with meth, you've got upwards of 300 and 340. And then the counties, Cabell County still is leading. Again, these are the 2017 numbers: 168 overdose deaths, Kanawha 119, Berkeley 74, Raleigh 53. And then another, I didn't do a per capita analysis, but two that kind of stood out for me. One was Logan, which seemed high, which was 22. And then Wayne County, which was 26, and that was higher than most of the other southern West Virginia counties. And I'm concerned that these issues that are in Cabell County are trickling down to Wayne. So again, I struggle with, I see so many good people out in the audience. Many of them are out here doing all the right things, yet our problem keeps getting worse. But I do have confidence that we're going to, I don't know if solve's the right word, but certainly curb the problem with the talent we have here at the table, the people in the audience, and the new drug czar to my right.
So Eric has already introduced Dr. Michael Brumage, and Mike is the Assistant Dean for Public Health Practice and Service in Charleston from WVU, and most recently was named as the official for the Office of Drug Control Policy, i.e., AKA the drug czar. Mike.
Well, good evening, everyone. And I would echo Eric's comments that this is the most complex public health emergency I have ever seen in my lifetime. And the statistics are staggering. And I think we've been almost bludgeoned by the kind of statistics that we've seen on a day in and day out basis. And the problem apparently is getting worse by the year. But there are some glimmers of hope out there on the horizon. For example, last year, the number of overdose deaths in Kanawha County actually fell. So that's a turning point. And my colleagues at Cabell County, at the Cabell-Huntington Health Department, are telling me that while they went up in Cabell County last year, they're starting to plateau in the last few months, and they're hoping that this is the beginning of a trend. So there are some glimmers of hope out there, but this problem did not start overnight. This has been generations in the making, and it's going to take decades, if not generations, to measure our outcomes. This is a long game. We have to be in this for the long game, but there are things we can do today in this present moment to help change the trajectory of where we're going in the future. When I look at the opioid epidemic, which is really just one epidemic in a constellation of other addictive behaviors. So that's the important part to remember. This is not in isolation. Otherwise, we have programs that we're playing whack-a-mole with, where we have smoking cessation campaigns, alcohol campaigns. We have opioid response plans. The state has an excellent opioid response plan that was put together by Dr. Rahul Gupta and a very esteemed panel of experts from across the United States. As bad as things are today, one of the things that I'm hoping that we can address is to change the dynamic here and change the narrative a little bit. Not to put a happy face on a bad situation, but there are these glimmers of hope. And there's a psychology of despair, fear, hopelessness, which is really the fertile soil in which this weed, as Clay refers to it, grows. We need to change that, and we need to change it into one that there is hope, and to point out that the people, for example, in Cabell-Huntington, where I'm going to visit tomorrow, who are doing wonderful work there with Marshall Health and others, there are good stories to tell, and we need to get that so that we can bring people to the table and make this a virtuous cycle rather than a vicious cycle of only bad news. At the same time, we have to attend to the tremendous suffering for people who are actively using. We treat them often like modern-day lepers, and we treat them really far different than we treat people with any other disease. This is something that has to change, and the stigma around IV drug use is one that we have to be able to change to make some progress. Because by holding people away, it's the fear-based way we deal with people we are uncomfortable with. We need to bring them in and bring them closer. At the same time, you talked about the families and the tremendous suffering that families with people who are addicted or people who died. And we need to attend to those families because their suffering obviously did not end, as you pointed out already. But I'd also like to point out that there is another part of our population that's deeply affected, and that's our first responder community, who has been completely overlooked up to date. These are men and women who are doing tremendous work day in and day out, and on top of all the automobile accidents, strokes, heart attacks, they're responding to people who are overdosed, often with children in the room. It's tremendously traumatizing. And so we need to pay special attention to our first responders. I'm fond of the Johann Hari quote, "The opposite of addiction is not sobriety. The opposite of addiction is connection." And so that's where I'm going to be spending a lot of time, is working to try to connect people. And this is going to take a 360-degree approach. Every citizen in our state has a role to play in this in some manner or another. And so that's where I'm going to be really focusing a lot of my efforts as I move forward. We're going to be paying attention to jobs, housing, our built environment, the social determinants of health, and something called adverse childhood experiences, which is a powerful driver for the intergenerational suffering that our children have around the opioid epidemic. But I do believe that there are ways that we can really begin to address this here and now. Thank you.
All right, very good. So we have an esteemed panel. You understand what each one of them brings to the table. Now it's your time. We want you guys to ask the questions that you are curious about. No bad questions, no question that's not important. The students will come to you, raise your hand, and the students come to you, and we take them as the students come. Students, up, go find the questioners, please. All right, first question, please.
Hello, thank you. It's a privilege to be here. My name's Paul Ballard. I'm from Sissonville. I have 3 grown children that are drug addicts. It's a lot of shame on me because of all the times they've been arrested, 7 days in, and public returned out of it, how it's PR'd, I'm not sure. But anyway, through the system, they've been in trouble a lot. They've lost a lot of hope. They have no desire to work. I've been called everything, including an enabler. And I've taken on that mantra and didn't want to wear it, but I had to come to terms with it, especially when my wife had to turn herself in down here at the emergency room the other night because she's 63 years old, worked 29 years for Sam's Club up here and could not work her job no more because of the hands being stuck out, because of the lies, because of the theft, and everything going on. But what I want to say is, as much shame as it brings to me, these are people, and these are my children. I've lost brothers and sisters to drugs. I've lost a brother-in-law to drugs. My family's been impacted greatly. I spoke to someone earlier here today, about 15 people I know in the last 10 years. They're no longer here, classmates and stuff, because they did not ever find a way to break that cycle. And what it is, specifically, is do they have value? Does their life to themselves has value? Because when they find out they don't have jobs and they start losing everything, it spirals out of control. They start doing things like asking anybody, and let's call it mooching or bumming from the family, to stealing, to pawning everything they got, to losing jobs. So what I want to say is we have to try to find something that's long-term. And I know that we're trying to catch up with it. And I know some of these facilities have done a good job with their 7- and 10-day detox. But what happens, what's their record or percentage of success? I'll close by saying that to the faith of the Lord that come over me in the last 5 years of my life, changed my life. And I realize that the church I go to has several grown men in their 40s and 50s that testify that they, in behind of a coal truck, a man come to them and talk to them about the Lord. They become spiritual, and they was able to break that bond. I'm telling you what, spirituality has to be a part of this rebirth. Now, I'm not going to what direction, but I'm saying that's a part of it. I know that's a long minute to talk.
No,
I've been privileged to talk here right now, but I'd love to figure out a way to get long-term help in West Virginia somewhere. And I just wish I was a multi-trillionaire. And I know throwing money is not always the answer, but there's a lot of good people trying, and they're frustrated, and there's a lot of people that's in battle, and I watch them battle daily. I had to lock my doors and lock and put them out. That's according to the police, according to the doctors, and everybody I spoke to lately. We have been in fights. They've been declined mental health. My youngest son is an Iraqi veteran. 17 years old, he had to be held up at Fort Hood when the shooting took place because he wasn't even old enough to leave, to go to Fort Dix to leave out with his company. And he went as an 18-year-old acting 14. I'm sorry, he wanted to be a man. He came back with a wad of money, didn't come home, got on drugs, and that's how he paralyzed and went spiraling out of control.
Thank you for your question. I'd like Frankie maybe to take the first shot at that, and Mike maybe you take the follow-up.
First of all, sir, I applaud your courage for standing up and for saying that you have addiction in your family and the problems it's created. Part of what happens with this disease is families keep the secret. And then not only do their loved ones not get help, but they don't get the help and support they need. We wouldn't do that if our family members had cancer, would we? We would tell everybody, and we would rally around that family, and we'd do everything we could to support them. So I applaud your courage. And I also want to acknowledge that indeed, it's this terrible reverse sort of thing that a parent has to do. A parent is taught and told and knows from their heart that they're supposed to protect their child, and that means trying to reduce consequences and save them. And yet it's the very sometimes opposite of the thing that needs to happen with a child that's in active addiction, and that is just so, that's horrendous. And I think that's such a difficult journey for a parent, and I respect that you're to the place that you know you need to do that, but I also respect how hard that is. I think you're exactly right. This has got to be a long-term solution, and when you say spirituality, good treatment includes a focus on spirituality. For some people, that's religion, and it sounds like it is for you, sir. For other people, it can mean different things, but you're exactly right. Connection is a key part of spirituality, and you're hitting the nail on the head, and I think it gets into some of what the two good gentlemen in the end were saying as well. So, if I could ask you, have you, if it's not too personal, have you had the opportunity to access any Al-Anon or Nar-Anon resources, or are they in your community? I don't know. So Al-Anon and Nar-Anon, and if you're from the Charleston area, I imagine they have those here. Those are support groups for people who have people in active addiction, and the focus isn't on the person with the addiction. The focus is on you and your wellness and how you can take care of yourself in the face of that disease in your family.
I'm broken. I'll interrupt you. I'm hurt. I've cried 1,000 tears, and I do believe in faith, and I'll never quit praying about it, and I should turn it over and leave it to the Lord. But my wife finally just said she stopped believing, and she told Dr. Hani Naji. She said, I stopped believing. Man, to see your wife.
Yes.
34 years to say that, because I know she's been great. I'm embarrassed to say that I'm crying right now. I wish that I could take a few of you guys and y'all could keep me for a week somewhere and come back and talk to me again. But I'm talking to everyone right now. I'm the face of a broken family where everything's tore up. No one trusts anybody. Everybody's on eggshells. You never know when somebody's going to come home stoned out of their mind. You're going to watch them sleep to see if they're going to breathe. They've been close to death. Narcan, come to the house because two guys dropped my youngest son off there, and my wife heard a disturbance on the porch. You go out there and look, and he's laying across a chair. He's incapacitated, and they lay him down, and they take off running. She hollers at him. She hollers for me. I come downstairs. We take and lay him down in the couch, and this happened a year ago. And next thing you know, he's blue, and he's not breathing. And she said, call 911. I said, yeah, you call 911. And I was talking and hollering, and they came fast. And next thing you know, they hit him in the leg with it, and he raised up like that. And it did happen. But how many times do you want to do that? Because I'm not to the people that wants to keep doing that to people. I want to have a big island to put them on. And see, that's the hate from inside, and that's not Christian. That's not.
Well,
that's
sir,
the struggle I've had.
You are why we're here. So please don't apologize for your tears or your angst. You're why we're here. And I really do want to encourage you to seek out an Al-Anon or Nar-Anon group in your community, because then you can be with other people who are working on their own recovery, their own wellness in the face of this addiction, so you don't go down with the ship.
And Frankie, maybe we can guide him after the panel. Sure. Mike, how about you? What do you think about the long-term solution here?
Well, I want to address this man's suffering first and foremost. Sir, it took tremendous courage to tell us the story you just did, and I just want to hold your story in awareness for just a second. But I will tell you that in Sissonville, you have Cabin Creek Health Systems, and they have a wonderful clinic there. If they can't plug you into services there, they will find a place where they will. They're really good folks up there in Sissonville. You're absolutely correct. There has to be also a spiritual solution to this, and I agree with Dr. Tack completely on this, and I applaud you for seeking that foundation in your life. We are all broken. All of us are broken. And we have to find it in our hearts to have compassion and love, because that's more powerful than Narcan, is compassion and love. And so keep fighting the good fight. What I will also tell you is that the people I know who are in recovery have the most profound wisdom of any people I've met. So if and when your children come through this, you're going to be stronger as a family.
Thank you. Other questions? It's a hard one to follow. There's students. Oh, you have one over there? Okay. We'll get you next, please.
Thank you very much. I'm David Hall from Pinch. I have a granddaughter that gave me a couple of great-grandchildren. Couldn't ask for any better. Where she's at tonight, I don't have any idea. But drugs got her. They're going to keep her, I think. But your panel and all of you up there, I'll give you a little country advice from up Pinch. 3 things you ought to do. Every day, you ought to laugh, you ought to cry, and by God, you ought to think. And I don't think many of you are thinking. The gentleman that's talked about the economic issues. Put a tax on the gas we just found. They're going to ship 54 billion cubic feet a day out of here. $1 a piece on there. You don't have to collect taxes for 5 days. Run the whole state. Think a little. Now, what you can do with my granddaughter, I'm just waiting somebody calls and we'll bury her. And I hope her children learn from this and things work out. We could help get the families involved by simply passing a bill in the legislature like they have for a hygiene bill for me. When I get about old or a little older than I am now and get crazy, well, my kids are going to put me in a home somewhere because they sure not going to take me to their houses. So you go up in front of the judge and they put you there. We don't have that right as parents unless the child is living in our home. We need to have that right so we can get them in rehab and get a crack at them before they get real excited. Now, I used tobacco from about 12 years till about 20 years ago, and I'm 80. It's the hardest thing I ever got rid of in my life. 3 years and 9 different times I tried to get rid of it, one time for 9 months. So I know what you're talking about with addiction. But I would think that with good thought, and it looks like you all are trying, but just try a little harder. Get the family involved in this thing. Lord, we don't know what to do, but if we could get them in rehab, it would be wonderful. And the only way to do that is to have laws on the books that we can do it. So think about it. Thank you for your time.
Thank you. Allie, why don't you comment on the brain chemistry of addiction? What happens actually when people are addicted?
Yeah, so I think that's a very good point, whether it's a cigarette addiction, nicotine, or alcohol, or any kind of opioids, and we discussed many of them, fentanyl, cocaine, meth, all others. What happens is it's fundamentally addiction is a brain problem. And physiologically, the first time you have cocaine or you have cigarettes or opioid, depending on the intensity, your brain physiologically changes. The settings change to a different level, so it craves more. So fundamentally, Clay and others, this is a brain condition that we need to understand more across all addiction, not just opioids, but all addictions, and then help develop technology to help manage it better. And they arise a lot of times because of social situation, background situation, childhood trauma, or many other situations that happen in someone's life that makes you more prone to addiction, but is fundamentally a brain problem, and we need to understand it better.
And Eric, maybe I can follow up with you. So one of the comments was sort of some of the laws and policies that may either facilitate or impair the ability of families to be able to get their family members treated. So what is your thoughts on, on your experience and your reporting about how we might better facilitate this? I don't know if that's a fair question or not, but. Sure.
One of the issues, and Dr. Brumage can talk about this as well, but we see over and over is, and also Chief Rader, they respond to these overdoses and the person survives, and then they can't get them into treatment. They wake up, they say, I don't want to go. There's currently some legislative, I haven't seen anything hit a committee yet, but there's some legislation that's trying to address that. But I think that's something that's crucial, is trying to get these people into treatment. As we talked about with the first responders, they're going to the same house 2 or 3 times a week, 6 or 7 or a dozen times a month. Chief Rader knows this. If you've seen heroin, you see this. And the other thing, one thing he mentioned that also got my attention was, is there some way to tax the big pharma and put that money towards treatment? There was a proposal, it was kind of convoluted. In the governor has a opioid bill, and there were some amendments that somebody tried to do that. It was a little unclear exactly how that was going to work, but I think that would be one way to generate a lot of money. I don't know if it has to be done on the federal level or the state level, but it seems like it's been long overdue.
Very good. Okay. Next question. Our students need to find the questioners, and please.
Hi, my name's Tally Sargent. And first of all, I just want to say to the 2 gentlemen that asked the first 2 questions, there is a village of us out there. My sister is a 25-year addict in Huntington, actually. And my mom, who's 65 years old and a public school teacher, is raising her 3 children. And the one thing that's missing up there in the discussion so far is, how are we breaking the cycle with the next generation of young West Virginians? Right now we're playing whack-a-mole with people like my sister. But what are we doing, and I see Andrea Dar is here with Handle with Care, but what are we doing for these young people like my niece, who's 11 years old and just on the cusp? Thank you.
Thank you. Sally, why don't you start to think about addressing this issue related to your work in the past with other vulnerable communities and what the impact of that is on children and people that are in those families that are affected by these kind of traumas.
Thank the 2 gentlemen and you as well for your questions and also for your honesty. And I wouldn't pretend to have the answers to these questions. I think they're very difficult, but I think it's very important. There was, mention of the huge stigma that individuals who have an opioid use disorder many times are not treated as persons, and that's really internalized by the family and is really very devaluing. So I think, the first thing is communities, and I think the communities here have really started to do that folks have to be met where they are, and we have to understand that these folks have a problem but deserve respect. And it may take, as the gentleman over here said, I think it took you 9 times before you quit using tobacco. Many times with individuals who are using drugs, you know, it takes multiple times, but there comes a time when, you know, they will actually, in some cases, really want to come to recovery. So that's one thing. I think the second thing is that, you know, once you are in recovery, it's all about people, places, and things, as Raleigh Sullivan used to say. And in the state of West Virginia, to my knowledge, we really don't have sober homes where individuals can go if they're on medically assisted treatment and live and start to be able to have employment. And I think that that is hugely important. I think getting back to your question about the children, I mean, again, harking back to the AIDS epidemic, there was a generation there raised by grandparents where, you know, the parents were either dead or unable to care for those children. And I think that families have enormous strengths. And I think that an important point is for those children that they have someone who loves them, who values them, and who can really express that. And the hope would be that at some point their mother would be in recovery, get the help she needs, have the environment that would really facilitate her to be able to stay sober and you know, help as well. But it is a profound problem, and I think that there's no one answer for any one family.
Mike, before you start, I want to recognize Secretary Bill Crouch, who just came in from the Capitol. So, Bill, thank you for your leadership. He is the Secretary of the Department of Health and Human Resources. So, Mike, you've really championed this adverse childhood experience approach, and maybe you could address this issue about our generation of children. I think this is really, really important.
Yeah, Ms. Sargent, thank you so much for asking this question. And what you've touched on has not really been addressed anywhere in the United States in any sort of comprehensive way. As Andrea Dar, who you pointed out, is fond of saying, drug-endangered children are now having drug-endangered children. Did I get that right, Andrea? So we need to break that intergenerational cycle. And that's really where the gold is in this whole epidemic. If we want to stop the next generation or the generation after that to attenuate the use of substances to alter our experience of reality, then we really need to have trauma-informed approaches. And there are many examples out there that are being successfully implemented on smaller scales, but also even here in the state of West Virginia. The Handle with Care program is one of the examples of how we can deal with traumatized children in the household. So you've touched on something extremely important. Maybe people don't know, but Cabell Huntington Health Department in their harm reduction clinic asked their patients who came in what their ages of first use were. You want to guess what those ages were? 11, 12, and 13 are the ages of first use. If we go into middle schools, we're already too late. We have to get this kind of care into the elementary schools and continue it on all through high school if we want to have any kind of effect. And unfortunately, what's happened is that we've put another burden on our teachers and our schools, because that's the last safe haven that many of these kids have, where they may have the opportunity to have an adult who loves and cares for them and lifts them up and provides them with some sense of resilience. So I'm glad that you asked that. I think that is the golden question, and I'm going to be working with my boss, Secretary Crouch, and the governor to see what we can do to advance these kind of ideas, because there are really good ideas out there that how to do that.
Hey, Mike, really briefly, because we want to continue the thing, talk just about the Adverse Childhood Experience Survey. I don't know if everybody's familiar with that, but I think it's really important.
Can I just see a show of hands of people who've heard about the adverse childhood experiences? Wow, look at that. Most of the audience has some familiarity. For those of you who've not, basically everybody, this is a large study done with over 17,000 people at Kaiser Permanente in Southern California. And what they were looking at are 10 categories of abuse, neglect, and household dysfunction. It's specifically talking about emotional, physical, sexual abuse, emotional and physical neglect, one or both parents missing from the household, substance use in the household, mental illness in the household, domestic violence specifically toward the mother, and an incarcerated member in the household. So everybody in this room has an ACE score between 0 and 10. If your ACE score is 4 or more, you're 10 times more likely to use intravenous drugs than if you have an ACE score of 0. If your ACE score is 6 or more, you're 46 times, not 46%, 46 times more likely to use IV drugs than those people with a score of 0, and on average will live 20 years less. So this is a risk factor. It's not a predetermining factor. So if you're sitting in the audience, you're going, oh my gosh, I'm going to take 20 years off my life. The most powerful resiliency factor, in addition to the ones that we have ingrained within us, is the presence of a loving, caring adult in somewhere in that child's life. That's a lifesaver. And those are the things we can do specifically, is get responsible, caring adults in with these children who are at high risk.
That is very powerful. Thank you. Other questions?
My name is Victor Gregoracci, and I appreciate really Dr. Clay and all the others participating in this tonight. This is really a marvelous discussion of the issue, so thank you very much. I'm having a little trouble trying to sort through my mind as the question I want to ask. First, I want to talk with Eric for a moment. I appreciated the articles that he did, and that helped me understand some of the flow of the opioid effect, but I'm still not clear about all the pipelines. There has to be more than just the drug companies. There has to be an awful lot of pipelines out there to get to those drugs, whatever they might be. Plus, there has to be a flow of money to do that too. Perfect. I've not heard any discussion about how you stop the flow of the money to prevent these things from happening. And then I'm struggling with what causes a person to do this anyway. And so if somebody could try to help me understand that, what motivation causes this to do it? Is it the high, or is it, I don't know what it is that causes these things to happen. And I have some other questions, but I think that's enough for the time
So I think this is a layup. So Eric, you go first, and John, you follow with the economic part, and I'll address the what causes people to do that by punting to Mike. No, I'm kidding. Eric, please.
Well, the flow started with these pain clinics. It's been 20 years, I guess. I don't know if you guys saw the news this afternoon, but they indicted a bunch of people who were involved in the Hope Clinic, which is just down, it was in Canal City for many years. We all drove by it. We saw the long lines of cars. We had actually been reporting about that back in 2014, 2015. They had retired police officers actually carrying guns in the facility, taking people's weights, taking their blood pressure, and actually churning out prescriptions by the hundreds with these special machines where they had just stamps of the doctor's signature, and then taking them. Hope Clinic had a special arrangement with Trevelyan's, if you recall. And so it started with that, and then you had the pharmacies that were complicit, and then you had the drug wholesalers, the distributors that were shipping these massive amounts of drugs to pharmacies. There's been a congressional investigation ongoing where they're uncovering the specific names of the companies and which small-town pharmacies they shipped to. There was one in Logan County, Family Discount Pharmacy. They got 16-point-something million pills in a small little town. You've all heard about the Kermit situation. And then at the top of the chain, you've got these manufacturers. One everybody knows is Purdue Pharma, which marketed their OxyContin as non-addictive for years. So you have this sort of Some people have described it as sort of this like legalized cartel, which sets up this pipeline. And at the end of the day, and through my reporting, I mean, when I've interviewed these people over and over, and they all point the finger at somebody else. They never point the finger at themselves. And it seems like nobody ever wants to take responsibility for any of it.
And John, you want to address the economic sort of issues that are involved in this?
Sure. Victor, by the way, it's great to talk to you again. I've spoken to Victor many times before. Part of your question was what causes it. I certainly cannot speak to so many of the causes like what my colleagues up here talk about in terms of the medical side of it, but certainly one part of the cause is, lack of a job. I really appreciate what Dr. Marsh, his comments sometimes about the importance of purpose in life. If you don't see a purpose, if you don't have a purpose, you can suffer in so many ways. And that relates to this issue. If you don't have a job and if you don't have something that you're looking forward to and something that you're building, working towards in the long run, then certainly that increases the risk of taking up opioids. I'm sure that's one of the risk factors that Michael mentioned before in the survey that he mentioned. So certainly, developing our economy. And I mean, earlier I said that tackling the opioid crisis is a big part of developing our economy. But by the same token, as we do more to see economic growth and to provide better opportunities for people in West Virginia, then that will help, at least to some degree, help reduce the problem in the future when people have more of a purpose and more of a vision for where their life's going in their job, in their career. That'll help. It's not everything, but it certainly will help. Part of your question as well was where does the money come from to fund this someone's drug problem? I don't know the answer to that. I don't know. I've talked to people many times before about when the economy suffers, when people start losing their job. We always see increases in drug abuse. And I've had people ask before, where do they get, if people who lose their job are more likely to take up drug abuse, then where does the money come from? I'm not for sure where it comes from. It comes from borrowing and, getting money from family and friends. Sometimes it might come from crime. Of course, crime is highly correlated with this as well. But I don't know all the sources for that. But certainly, promoting the economy and promoting economic opportunity is an important part of preventing this from getting worse and getting back to normal.
And I would just sort of focus on the last part of your question and ask Mike and Allie, and then I'm going to ask Frankie and Sally too, but talk about the role of chronic pain in the addiction problems that we have now, the dealing with pain as a driver of the opioid epidemic. Mike, maybe you could say that, and then maybe Allie, you can talk about some of the innovations that you're starting to lead around the issues of chronic pain, particularly back pain and other common sources of pain.
Yeah, so unfortunately, opioids don't only treat physical pain, they treat psychological pain very well. Even the word heroin was a German invention. It was a German pain-killing drug, but it was named that because it allowed people to be heroic in the face of pain. So people who I've spoken with who've used have told me the powerful effect this has over their body, that not only their physical pain melts into the background, it's still there, but it melts into the background, but there's this sense of euphoria that's so strong, so that if you're in emotional or psychological distress, it's very powerful at numbing that as well as the physical pain that you have. So it's easy then, once you can have a physical pain, and people figure this out pretty quickly. That's the ticket of admission. I have this back pain or I have this headache, and it has all these vague symptoms. And when the drug companies are marketing to the physicians that this is a non-addictive pain medication, then okay, go ahead and take this. And then for those people who are susceptible to that, then they're kind of hooked.
And Allie, talk about the innovations that you are working on to try to deal with pain in a non-opioid, non-narcotic approach.
Yeah, so pain and addiction go together. So chronic pain is not only a physical issue, a sensory issue, it's also a behavioral. As it gets progressive over time, involves cognitive parts of the brain, behavioral, emotional parts of the brain. They're all linked together. and they're very closely linked. So some of the technologies that we're working here and at West Virginia, and some of the world's experts are here in the state now as we're trying to combat this opioid crisis and chronic pain issues. This state has some of the best people in the world to tackle these issues up front. And so some of the technologies are local delivery mechanisms, tiny implants or tiny chips, pellets that dissolve over time, that deliver a non-opioid medication that can treat the pain locally without the need to bathe your whole body systemically with a pill. So these targeted approaches are very important for future of how we manage chronic pain and not need or be dependent on medications. And West Virginia is going to be on the leading edge of these new technologies, targeted implants for treating various chronic pain syndromes.
And talk just briefly, Ali, about virtual reality and other technologies.
Right, so virtual reality is being used very commonly for gaming, and there's a multi-billion-dollar industry, but there's the next generation of virtual reality technologies that's coming that can use some of the handheld devices that you all have, coupled to some additional adapters that allow you to use this technology to get very precise biofeedback. So, for example, if you have an addiction problem, and addiction is an anxiety, is a physiological problem, so the biofeedback from these virtual reality systems can help guide the individual to go to a position of safety, a position of comfort, a position of reduction in anxiety, and that basic technology can be applied with some of the teams that they're working with here in West Virginia. And virtual reality is now being used for recovery from a stroke. If you have a stroke, you can use virtual reality. It's FDA approved now to improve motor recovery. It's being used for chronic pain, and we're looking at it for addiction. So this technology is not only for gaming, it is for treatments and also detection of the physiological correlates of addiction or pain.
So, and I'm going to follow with Frankie and Sally. So one of the questions was, what's the cause of this? And maybe talk a little bit about your experience with this idea that Mike said earlier about the opposite of addiction is not sobriety, the opposite of addiction is connection. That was Johan Hari, and Sam Quinones, who wrote a great book called Dreamland, said the basic reason why people are addicted because they feel very isolated. And we know that the root word of health is wholeness, so the isolation and fragmentation makes people feel incomplete, and some people turn to drugs or others to escape that feeling. So maybe you could address that.
Yeah, I think we have to remember that nobody that first engages a drug is engaging to be an addict. No one who drank their first glass of wine or drank their first beer or smoked their first cigarette thought they were going to be addicted and have a horrible cascade of consequences for them and their family and their community. They thought they were going to have a nice, pleasant experience. The problem is some people have vulnerabilities and probably significantly biological vulnerabilities that drug resonates with their neurology in such a way that they very quickly escalate with the use of the substance. I really don't like the term drug of choice, which is a common term you hear in addictions treatment. I don't like that term. I like primary substance because I don't think people choose drugs. I think drugs choose people. And by that I mean, how is it that I could have surgery and take an opioid and take it for 3 or 4 days or a week because I need it for my surgical pain, and then not have any interest in taking it anymore, and someone else takes it and suddenly feels like, wow, I have found my thing. What's the difference in us? There's got to be something different in the neurology. And I actually have a colleague I was talking to this week who recently had surgery. His physician gave him, offered him opioids, and he said, well, I don't know if I'll need them. And he said, well, I'll give you just 12 days. And he said, well, how about, my colleague said, how about you just give me 10 days? And so 10 days post-surgical, For a few days, he took them every 4 hours, and then he started, like, well, I can just take one or a half. His pain's better, but he realized, wow, he really enjoys how he feels at night, and he slept better taking the opioids. And he told me, he said, wow, it really stunned me how quickly that could happen. His body resonates with that. And he said, I think I need to get rid of the rest of them. And I said, capital idea. But so I think, nobody sets out to develop an addiction. But it's a slippery slope. And I think with opioids, particularly with some of the prescribing issues that we've had and things that it's been very easy to fall down that rabbit hole for people, and especially when it comes to issues of hopelessness, isolation, economic issues, all the things we've got going on in the state. We've had a perfect storm. Motivation to use, hey, it feels good. We'd all be high right now if there were no consequences, right? It feels good. But some people, neurology resonates in a way that leads them down the rabbit hole. So
good. Sally, anything to add?
Yeah, I would just say we haven't talked about the provider's role here. We talked about the pharmaceutical companies, but another critical feature was that there was this fifth vital sign, which was pain, and sort of the smiley faces. And I can remember, I was a practicing physician, ran a big HIV program in Newark, and a lot of our HIV patients had chronic pain. And if somebody had pain and you didn't do something about it, when they reviewed those charts, you were asked why not. At the same time, you had pharmaceutical companies produce specifically based on a letter to the New England Journal, not peer-reviewed, saying this is not addictive. And so we got into this model of saying we can treat pain with a pill. And I think that really what has come about there, West Virginia is a place where people do work, they get injured, it's painful, they need to stay working to provide for their families, and they go in and say they have pain. And I think in some cases we're given opioids just along that paradigm. And I think as we've come to understand this, that has really changed. And for example, the chronic pain clinic, WVU, is working with the Uniform Services Group and has really redefined the pain scale. And it's not, do you have pain? It's that, how does that affect your function? And the second aspect is that, there are lots of other there's massage, there's acupuncture. All of these things previously were not covered by insurance, so it was very hard to really treat pain. And I think these are some of the areas that are switching, and I think are going to put us in a much better place.
Great. Okay, so we're at time, and what I'd like to do is ask each panelist very quickly to leave us. Okay.
We should not be applauding a senator. We should be applauding these people that are in the trenches fighting for their lives right now. And we're not helping them. We're here, we're talking the same bullshit over and over and over, but I don't see any changes being made. Recovery Point's working on a minimal budget, trying their best to save these people. And these talks have gone on for a couple years now. Where is the help? Where is the long-term help? My daughter went to Kentucky to get it, and it was an exceptional program because West Virginia did not have it. WVU, when she was there, did not have it or address it, and that's where her heroin addiction began. I can't let these addicts not be heard today. I mean, we're down here, we're making notes. We look good because we're here. We're not the good people. Our good people are our kids that are out there, and that the firemen, that the paramedics, all these people see every day. But I am just like, why is there not an addict on the table up here talking about what works for them? We should not be making decisions for them. Ashley didn't go out and say, I'm going to be a heroin addict today. No, she was a homecoming queen and an honor student. So she should be up here. Her voice needs to be heard on what works and what got her clean, not what we are assuming what's going to get our kids clean. So that's where I'm standing. We should be applauding our kids.
Yeah, well, thank you for your comments. So I'm going to ask our panelists to make a takeaway from their perspective, and maybe we can address the final question with one of our takeaways here. Why don't we start here with Ali?
Yeah, I think I'm very excited about the opportunities here in this state and the what you hear from this panel and also in the audience about the multiple teams that are going to work together to tackle this crisis. And from a technology end, we're going to leverage the latest technology to help individuals to prevent the addiction, monitor it, provide rapid feedback, and also treat addiction. So that is a pledge from our end, and there's a lot of opportunities here, in my opinion.
Great. John?
I don't claim that I've done much at all to tackle the problem, but what we are doing in terms of trying to really quantify the economic losses to our state from this problem, I mean, to convince policymakers and leaders in the state to invest the resources and to make the policy changes that are needed to tackle this problem, we have to show them how big the problem is. We have to justify to them that this investment of this many resources would be worthwhile because the problem is this big. So for what it's worth, the work that we're doing to try to make people understand how much we're losing out, just from a purely economic perspective, will hopefully help people understand the need for investment and for policy changes, because it's worth it. I mean, the problem is big enough to justify, major intervention.
Great. Frankie?
We have to wrap our arms around the families. I mean, that's my takeaway tonight. I think we need to ask, our neighbors, are you struggling with addiction in your family? How can I support you? And if you're struggling with addiction in your family, tell your community, ask for their support. We've got to bring it out of the shadows. And your point was very well taken, ma'am. And I'm sitting here thinking, why didn't we do that? I'm really sorry. I apologize to you. You're exactly right. So let's wrap our arms around everyone.
Good. Sally?
I also want to applaud the last woman. You're absolutely right. And I think it's that sort of passion and demand that you must have treatment that's available. And individuals in recovery that are successful, I think, will really be, the leaders for many others who are searching for that. And it's really all about communities, local communities.
Eric?
And I'll third and fourth and fifth that about what you said about having somebody in recovery up here. That's the thing that I try to tell people, and I've been told before, that you have to spread the word of hope and recovery. We featured in our article a woman from Boone County who is now counseling people in recovery, and she was a former, she was arrested for OxyContin sales years ago. I got more emails and feedback than anything else I wrote in that story was writing about her. And the other thing, if you haven't seen Jan and the Judge in the heroin movie, that probably has done more for this state than anything that I've seen or heard, and galvanized so many people. And so congratulations on all that, and I hope you guys win that Oscar.
Mike?
So again, I was very moved by what you said, and it was interesting that the last person I spoke with before I came down to the auditorium was Matt Boggs from Recovery Point about what we can do to galvanize the recovery community, because there's so many people in recovery around our state. And there are many, I heard some new things here today about housing, what to do, and providing jobs. I'd just like to mention in passing, there is a fund, a scholarship fund called Bridge of Hope, started by Lynn Fruth, who owns Fruth Pharmacies. And this is a scholarship fund that will help people in long-term recovery to go on to get higher education degrees or vocational degrees as one example of how people can, around the state, can help with that. But clearly, we need to include your voices more at the table, not you, but recovery voices more at the table. I've been on the job for 15 days, so I just need a little more time.
And I would say, as my take home, that we can feel the visceral pain from people affected and their family members affected, and for that we feel for you and want to help. But our opportunity here is great. The problem is great, but the opportunity is great. And the opportunity is to start to rebuild hope and communities to the level we not only help the opioid epidemic, we also help the chronic disease burden in our country, and we can do that here. And we have the team, we have the committed people, and although certainly we're in early days, this is a mission, a journey, a fight, whatever you want to call it, worth taking together, because this is what our country needs to change healthcare from the high-spend, low-outcome experience we have today to something that's much better. So thank you guys for coming. Thanks for the Gazette-Mail for helping sponsor this. And thank you for our participants, our panelists who did a great job, and for our audience members.